Welcome everyone to our Ifso Apc Webinar. I think we're going to have two sessions today, and the first session is Ken Loy, me. I'm a bariatric surgeon in Sydney Hospital, current treasurer, but probably incoming president of Ifso Apc. Our current president is Prof Wang, and I'm very grateful that we had a chance to do this debate because this debate is intending to be fun and interactive, and please ask questions. I don't think anyone will be offended. We have our esteemed panel that's going to give us their view, a personal view in terms of what age they should start bariatric surgery and what age they think is the best time to retire. It's a little bit controversial because there's not much documented evidence, but in fact, they actually have taken up a lot. And helping me to moderate the session so that we don't end up in a fight. Luckily, we are only on the webinar, not in the real life, is Kazu Kasama, who is the past president. He's not only the past president, but if he's in real life, he will probably be able to stop the fight physically for us, because he's probably the fittest president we've ever seen in Ifso Apc. So nothing better than him moderating. Now, we have few recorded video. I'm going to introduce our, according to Asian tradition, we always respect our senior colleagues. So our first session is going to ask our two esteemed senior colleagues to give their view. Professor Pradeep Chaubey unfortunately cannot be with us, but he has recorded his view. And as you know, he's operated on Dalai Lama, and he's the past president for Ifso Apc, not only Ifso Apc, Ifso itself, and also Professor Harry Frydenberg, who is currently in full attire, just finished all his consult this morning. I believe he's probably seen about 50-odd patients today, and still in his suit and tie. It's 8 o'clock in Australia at the moment, so I'm sure he's going to tell us he probably shouldn't be retiring. So, and this webinar is going to be recorded, and it will be posted later on in Ifso Academy session and also in YouTube channel. So for anyone who interested in looking at that afterwards or sharing it with the colleagues, please do so. And I welcome everyone. And now we're going to go to the talk. Manuela, if you can load the talk for the first two talk first, and I'll introduce the two other younger speaker later.
Hi, I'm Harry Frydenberg, and I'm the director of the Epworth Centre for Bariatric Surgery in Melbourne, Australia. And I'd like to join you in this debate on the age of commencement and the age of retirement for surgeons. The age of commencement. In Australia, at the time of the completion of the medical course, one becomes a surgeon after 5 years by completing 2 sets of exams. The first base is the basic sciences, anatomy, etc. And the second is the clinical and performance after 3 years of internship. And so at 29, I became actually a fully fledged surgeon. Now, people will ask, was this too early? I didn't think so, because I had already a good training and ongoing mentoring, which was essential in this process. Today in Australia, it takes much longer. Graduates become surgeons at about 34. Are they any better? Not really. No, as the training is more specific to certain specialties, and they're not thrown in the deep end like we were, in that we were doing all sorts of different operations sort of by ourselves and learning on the job, and a variety of things from burr holes to bowel cancer, whereas today the training is much more specific and much more towards a particular specialty. So what is the age to become a surgeon? Well, my overall feeling is that any age, as long as the training and the mentoring are up to standard. So what about the age of retirement? We're all getting a little bit older, some of us more so than others. And what influences retirement? First of all, age. 65 has always been considered as the traditional retirement age for most professionals and workers, but if there is a mandatory retirement age, it actually violates discrimination laws in the country. And in medicine, it also sidelines perfectly competent doctors and can lead to the workforce being undermanned. In 2015 in the USA, about 25% of doctors are over 65, and in 2017, about 122,000 doctors were over 65. Now, surgery obviously requires stamina, cognition, and fine motor skills, and these may decrease with age, but not uniformly across populations. And some learned tasks and physical memory are remarkably preserved over a period of time. This article is from the Journal of the American College of Surgeons. Now, surgeons have a cumulative wisdom and clinical experience of the senior surgeon. It's an invaluable asset that should be honoured and maintained. In relation to health, personal health issues may contribute to a decline of the cognitive and technical skills. Periodic medical evaluation is an essential part of the assessment, irrespective of the age. The Royal Australasian College of Surgeons mandates that or recommends all surgeons over 65 to have a personal GP, whereas Stanford University requires medical staff 75 or over to have physical examination, cognitive screening, and peer assessment of clinical performance every 2 years. In relation to performance, people say, well, I can do it, I know how I'm going, but self-evaluation may fail to recognise or deny diminishing skills. So peer evaluation by direct observation, clinical audits, continuing personal development may be the means of performance assessment. And just an example of direct observation, as you can see, on the left is being alert, doing the job, looking at the screen, where on the right, you may get a little bit lazy and fall asleep a little bit on the job. Financial security is also part of the process in relation to retirement. A systemic review from the Medical Journal of Australia of retirement planning by doctors found that continuing financial obligations delayed retirement, while strategies to mitigate career dissatisfaction, workplace frustration, and workload pressure supported their continuing practice. In other words, if you have developed strategies to cope with all these things like dissatisfaction and frustration, then you're more likely to continue on practicing. Doctors need to obtain financial advice and develop a financial plan from early in their career, particularly if they are self-employed. Relationships are another thing. A sense of responsibility to patients and the central role that a doctor plays may contribute to the consideration of retirement. In other words, if you feel that the patient can't do without you, if you feel that you're an essential part, it may stop you thinking about retirement. Also, if the medical career is central to your life compared to other roles, in other words, marriage or other intimate relationships, unless dealt with, may delay retirement, as the doctor may feel he needs to be relevant, and that makes him relevant in this career. And so it becomes an important aspect of his life. Lifestyle. Having alternate interests may also influence the age of retirement. Business, sport, research add to an individual's relevance once again, and thus the need to continue their surgical career may have less attraction with subsequent early retirement. But not having these, regardless of any age, may prolong a surgeon's career. In conclusion, age itself is not the determining factor in a surgeon retiring. Health, competence, peer review, ongoing education, relationships, financial security, all alternate interests, all come into consideration in regard to the age of the retirement of the surgeon. So stay happy, healthy, and competent, and you can choose when you want to retire. Don't wait till someone taps you on the shoulder. Thank you.
Thank you, Harry. I think I forgot to mention. I think as a chair, I have failed you, Harry, already. We didn't realize you'd go first. So, Harry is not only our well-respected mentor for most of the bariatric surgery in Australia. He was the president for Ifso. He's still very active in the board of trustee and has published widely, and pretty much the grandfather of starting bariatric surgery in Australia. So now we hear his talk. In fact, it's full of scientific value. And I also take the opportunity now that I think Professor C.C. Huang's might be working. He's our current president of Ifso APC. He might want to say a few words to welcome us. Professor Wang? CC, are you on? CC, is there a connection problem? Now, maybe if there's a connection problem, let's just work on that. Why don't we go to Professor Pradeep Chaubey's talk, so then we can have a balanced view from our two senior surgeons in our Asian Pacific region of Ifso APC. Then we will have a little healthy discussion or debate afterwards. Thank you.
Hello, everyone. It's a great opportunity for me to be with you all again. And I've been given this responsibility to talk about the age of a bariatric surgeon. What is the right age? It's a very interesting topic, and I bring greetings from Max Institute, New Delhi, India. And as you know that the age criteria of age is very personal, but I will just let me sort of move on. Yes, so we talk about this. This is what I think the age means. Age is just a numerical, and I feel that everybody behaves differently at the different numericals. So age is no criteria. I think one should be physically and mentally fit, and that is what should be the criteria for any other surgeon. Now, very important is that at any age, especially when you are in a senior age, you should be working in an institution which has got the complete infrastructure support. Sometimes one gets retired and goes to the area and the hospital which does not have the support system. So that is not the, whatever may be your age, your infrastructure support should be there. And second, we always feel is that you have to keep on learning. It is not that what you learned 30 years back, because we are not born with the skill. The skill requirement for the surgeons keeps on increasing and also changing. So whatever is this state of art surgical practices and the protocols of that time, that is what you need to follow, and not to continue with your old traditions. Now, training is very important. Training is just ongoing process. It never stops. Every day you have to continue learning about the training. Decision making, I think for any surgeon, apart from the skill, it is important to have a proper and the right decision making. So if you are in a position to take right decisions, you can continue operating. Safety, I think every now and then you have to orient and reorient yourself with your own safety of your skill, safety of your decision making, which is important, unrelated with the number of years you are born with. Of course, the patients will expect you to be presentable, you to be under the control physically and mentally, and that is patient roles. Patient plays a very important role. So if you are physically alert, patient has got a confidence, of course you can continue operating. Then comes the complication. If you feel that initially your complication rates were acceptable and off late something is going wrong and your complication rates are increasing, that means that there's something wrong. You have need to be re-evaluating your own skills, your own decisions, and of course the support system. But important another point is the legal and social issues of your country, of your city, of your state, of your society. What are the requirements? If you fall into that, maybe you can continue without any hesitation. And of course, getting the patient, as I discussed, whether you would like to practice or not, if your patient doesn't want you to practice or participate, that will be possibly a day when you hang your boots. Then we talk about the sticking and bringing people together. So when you are young, you continue growing, you keep on getting your younger and younger colleagues. First you are attached with the senior colleagues, and as you become senior, you continue your team, you collect younger people with you, and this is how you build a team, because team is the most important part in all aspects, and it is more true for bariatric surgery. So you should be the leader of the team, which should include the anesthesiologist and the physician, endocrinologist, psychologist, and whole lot of people with you. Many times we have seen that as you are growing up, you, instead of collecting your team, you keep on deleting. You just fire somebody for various reasons which may not be very justified. So at the end of your career, you find when you become serious, you have got hardly any team. So I think you have to be accommodative. Don't just use the button of delete and escape, and make sure that your team is with you. And of course, you have to keep safety. Here you see the two persons, one a driver and a passenger. So whatever you do, I think it will be your moral and your conscientious decision to take and continue your practice, and find out that your patient should be safe, and of course you also should be safe in operating. This is the world's oldest and the fittest 96% person, the Charlie Sylvester, which is there on the record, and he's doing marathon running and all the gym, whatever you are doing. So I would say cheer up, thumbs up. You can also be like him and continue your practice till you feel that you're mentally and physically you're correct, irrespective of the numerical figures, whatever you have. Thank you very much.
Thank you, Professor Chabe. And I have to pay some respect and put on a shirt. I feel I'm underdressed comparing to Harry. Now I think we got Professor Wang back. I think there was a technical glitch. So Professor Wang, our current president in China, Guangzhou, during the lockdown probably soon at the moment with the COVID situation. Professor Wang, would you like to say something about our current webinar and our direction that we should take?
Okay, thank you, Henry. Ladies and gentlemen, Ifso Apc members. This is Ifso Wang from Guangzhou City, China. Welcome to the first Ifso Apc 2022 webinar. Firstly, thank you all very much for your continued support and participation in Ifso Apc activities. As you all know, the COVID-19 has changed our life in every aspect. The pandemic may have prevented us from meeting face.
Have you lost me?
Is he Professor Wang? Are you still here? I think overall he wants to set an example. He's one of our senior colleagues in China as well. Probably will.
But
Yes.
it cannot stop all adolescents of academic. Today is a brainstorming activity. Two very interested by
Is it the internet playing up, isn't it?
It sounds like.
Am I right? Yes. Maybe we'll carry on and invite Professor Wang back to do the summary sessions afterwards. I mean, to follow, I think our two esteemed senior colleagues, we also have our two up-and-coming star. The first one going to give us the view is Dr. Jadip Rao. I mean, we call him Jai, but I think it's a friendly name, and I think he's already a star when he first started. He worked in Singapore, and everybody know how good his skill is, and he's now a private surgeon, I believe, working pretty hard, also against COVID. And he's going to share his view for us in terms of when he first started bariatric, how does he start, and what's the best way to do it, and to entice some of our young up-and-coming surgeons to engage in bariatric surgery. Manuela, you take it away.
Hello, everybody, and I would like to thank the organizers, Nathan Zundel and the Ifso committee, for inviting me to have this chat. It's truly a privilege to be here. It's unfortunate this COVID situation is there, but I hope we sort this out very soon. Thank you, Ken, for moderating this session, and it's great to have this topic here. What is the right age to become a bariatric surgeon, and what is the right age to retire? So, my mentor said 2% of surgeons are born gifted, 2% of surgeons just cannot make it, but the rest of the 96 can be trained. Now, the youngest surgeon in the world is this guy, Akrit Jaswal, who became the world's youngest surgeon at 7 years. Of course, he was not accredited. He was doing surgeries and posting it on YouTube, and he did the first surgery for burns victim who asked for him. And then he went to med school and became a doctor at 12. However, in the rest of the world, this may not be the case. And for example, in a country like Singapore, we have a very stringent training program. And usually post A levels, which is 10 plus 2, we get into medical school. We have 5 years of medical school. We do an internship of a year. Then we get into a residency program, which lasts for 7 years. We do a post-residency fellowship, which is 2 years before you become a specialist surgeon in bariatric surgery. Now, of course, this usually takes about 32 years when you become a bariatric surgeon at the earliest, but it could take longer depending on when you get into your residency program. Now, the key factors in practicing bariatric surgery is, of course, training and experience. The factors involving complexity in bariatric surgery, because bariatric surgery is a complex surgery. It needs mastery in laparoscopic suturing and stapling. It has also complex patients which are morbidly obese with multiple comorbidities, and they need a multidisciplinary care and experience. And therefore, a certain amount of experience is required before you become a competent bariatric surgery. And what is this? Mainly, this involves learning curve. You have a slow beginning, you have a steep acceleration phase, you have a plateau phase, and from a beginner to an expert, you undergo phases of the knowledge, comprehension, application, analysis, synthesis, and evaluation. And this takes a certain amount of time, but we want to reduce this as much as possible. So is this possible in young ages? The principles of this involve expertise, volume, standardizing procedures, and making this reproducible so that we shorten a learning curve. Usually learning curves is dependent on the structure of a training program, such as type of supervision and expert of the trainer. And of course, an increased number of complications in the learning curve is no longer acceptable. When we look at the learning curves in specialist centers, we look at the subspecialty training, we look at what is the center volume and the surgeon volume. All these will decrease the learning curve, and you can become a bariatric competent surgeon much faster. In general, laparoscopic gastric bypass is considered gold standard, and the learning curve is about 100 cases, as done by this lovely study by Phil Shower and Ikramuddin. Advanced laparoscopic does decrease your learning curve skills, and therefore if you've had skills in other surgeries, this helps in learning curve. How to train residents to perform bypass, and there are CDs that can be done like this study showed, and if you have good supervision, you can actually learn this much faster. A systematic review by Antonio Torres and group showed this. They looked at two groups. The first group, as you can see, they're all pioneers: Phil Shower, Scott Shikora, C.K. Wang, and these people started doing surgeries on their own without having any supervision. And the second group are younger surgeons that were doing surgery under supervision. And when they looked at the complications between the two groups, you can see that group one, that means the senior surgeons, had more complications because they were pioneers in the group and they never had supervision. What this tells us is that you can be a younger surgeon, but if you have good training, you can actually reduce the learning curve and reduce your complication. Skills acquisition in this is very important, and an innovative approach was done by some of my friends, Camilo Boza, Antonio Lacey, Aradarzi, and they developed a training program and an assessment tool for learning certain things that you require in a gastric bypass, a jejunal-jejunostomy models, and 16 inexperienced surgeons attended this task force to do these certain things. And they then tested on respective tissue, time and scale, etc., how you move during the surgery, enterotomy, stapling techniques, etc. And they found that the jejunal-jejunostomy model differentiated surgeons of varying experience. And when they translated this, you could see that those who did this model and training program before the course, you can see that these are young residents, and there was a big difference between them and the experts. But after the course, the trainees were almost as good as the surgeons. Again, going to show that even a young year one resident can perform these skills if trained in a correct manner. And a bariatric fellowship showed that you can actually decrease the learning curve and reduce your complications. And therefore, we won't look at how young can it be. You can be very young, and if you have a good training program, then you can be a good surgeon and can start at a very young age. Now, when should a surgeon retire? This was a New York Times article that looked at surgeons who are too old to operate, and some said 70 years is that. But a lot of surgeons have been unenthusiastic about this idea. And the reasons are these. We have to define relevant areas of aging and what this will affect surgical performance. Define current standards with respect to retirement across the globe, because we don't have a certain time or age across the globe to say when to retire. Define what is known about specific outcomes in regards to aging. If you look at these different countries, USA, no mandatory age, Canada, 65 years, Ireland, 65, UK, no mandatory age, Italy, no mandatory age, India, 65, Russia, China, 60 years, 55 for women. This is not based on evidence. So 50 to 70 years has been a statutory retirement age in many countries. But if you look at it nowadays, older surgeons are on the rise. There's increased life expectancy. In the US, 20,000 surgeons aged above 70 years. 19% of the surgeons in Australia are more than 65 years. 18% of surgeons in Canada are more than 65 years. And they looked at this study, which is a very CRASS study, which is cognitive changes and retirement among senior surgeons. And they looked at surgeons outperform age match controls in all age groups. And the decision for retire-based surgery should be based on skill level rather than age. Therefore, you need, after a certain age, to perform certain skills and get yourself accredited from time to time to make sure that you're competent. We're looking at psychomotor skills. More than 40% had similar to that of juniors, even when they were 70 years and older. And 78% had similar psychomotor skills of juniors between age to 60 and 65. So again, 50 to 70 age, we can't really tell what is that age, golden age to retire. It should be more structured. So when should we retire? Aging process in the brain affects surgical ability, yes, but considering individual variation exists considerable, and therefore it should be based on individual variations and so-called accreditation after a certain age. and a one-age-fits-all model is not ideal for retirement policy. They should also focus, once people get older, say from 50, 60 years, then you start more on non-clinical roles, training roles, etc., because this can actually train young surgeons to be better and faster. What it took me 50 cases to become an expert, when I trained my junior, it took him 15 cases to be an expert, and these skills are transferable forward. So, of course, if you are young, like Harry or Pradeep Chobe, Harry Freiberg, he even beats us young people in tennis, in various other, in jogging, and he can still do surgery, and he can go on for maybe like this lady who's 90 years of age with no fatalities and doing 10,000 surgeries. But of course, we don't have all Harrys operating at 70, 80. And so we require it to be individual based before deciding when is that right time to retire. So thank you again for this wonderful chat, and we will again discuss during the time of discussion. Thank you very much.
Thank you, Jai. Thank you very much for your insight. It's actually quite evidence-based as well. We'll hold the discussion until later. I want to listen to my dear friend Wang, who is the incoming chair for certainly young Ifso chair committee. And I think he's working in Guangzhou with CC as well. And I think he's going to be interesting. He's widely published and certainly an academic and also hand-on clinical surgeon as well. So I think we're going to listen to what his view on starting bariatric surgery, and then we're going to have a debate discussion afterwards.
Hi, dear friends. This is Dr. Yang from the First Elective Hospital of Jinan University from China. It is my honor to be here today for the debate in the Ifso APC session. The debate topic is about the age of commencement and retirement of bariatric surgeon. I would like to elaborate my points of view in the following parts. First of all, I would like to introduce you the role to be a bariatric surgeon in mainland China. Then I will share some literature review about the age of commencement and retirement for surgeon or bariatric surgeon. At last, I will conclude my presentation. In mainland China, if you want to be a bariatric surgeon, first of all, you have to spend 5 to 6 years to get your bachelor degree of medicine. After passing the board exam, and you can be work as a resident. But nowadays, if you only got a bachelor degree, it is very hard for you to find a job in big cities like in Guangzhou and other big cities in China. So we have to spend 3 years more to have our master degree of surgery after graduation, and you also can apply for a residency in some big hospital. But if you want to be more competitive, you have to spend 3 to 4 years to get a PhD degree. That is to do a research-based training in these few years, so you can get a PhD. And after that, if you are interested in doing research, you can have your postdoctoral training. That will spend you 3 to 4 years. So the higher degree you get, the easier for you to get a promotion in the future. So after 3 to 5 years residency training, you can be attending, and you will spend 5 or 10 years to become an associate and the chief. So, and if you are lucky enough or you are hardworking enough, you have a clinical background and also research background. And after that, you can be a clinical scientist if you can get some very good research and get some good paper published in some high impact factor journal. This is the way how we become a bariatric surgeon in mainland China. I mean the experienced and well-known surgeon, and also some of us may become a scientist as well. So based on the long journey I just mentioned in last slide, and in my opinion, the age of commencement should be as early as possible, especially in mainland China. We got huge case number in clinical practice, and even when we were students, for example, when we are starting the master degree of surgery, we got a lot of hands-on opportunities, which supervised and guided by our mentor. So try to get more experience when we were young. This study from the MBS group shows that there's no differences observed in 13-day mortality between the surgical trainee and non-surgical trainee, but the surgical trainee patients had higher rates of post-operative DVT and and other post-operative complications. And this paper is about the surgical trainee impact on bariatric surgery safety. It shows that the failure training has higher complication rates, but it is based on the trainee's level. One more paper is about training programs' influence in the learning curve. It shows that bariatric training mentored by an experienced bariatric surgeon may improve the outcomes, and that is why it is important to have senior surgeons, or what we call old surgeons, give us guidance during when we were trainees. So about the age of commencement, for the patient safety, we have to get sufficient training, a lot of training, as much as we can, and of course as early as possible. Now let's talk about the age of retirement. This table shows the retirement policy for doctors in different countries. Most of them are between 16 to 65 years old, but some countries don't even have any mandatory age of retirement. This paper was from JAMA. It shows that the older surgeons have more experience caring for patients, which need to be balanced with the potential impairment in their ability to provide high-quality surgical care because of age-related functional limitations. But when should surgeons retire? This paper suggests that the competence should be assessed individually, and we should focus on the functional ability of the surgeon rather than just the age. This paper is about physician scientists, or what we call clinical scientists. It is a good choice for the senior surgeon to become a scientist. It connects the biomedical science and the translation of research findings to clinical practice. So about the age of retirement, after you become a surgeon, and later when you gain more experience, you will become a mentor, and of course later you can also become a clinical scientist. So about the retirement, I think you can stay as long as you can. This is the conclusion of my presentation. The age of commencement, I think it should be as early as possible. And about the age of retirement, and as long as you can contribute and enlighten the young generation, I think you should stay as long as you can. At last, I would like to take this opportunity to thank my two mentors. One is Professor C.C. Wang from Jinan University, and other is Professor Emin Xu from the University of Hong Kong for their guidance and for their support so many years. So thank you very much for your time.
Thank you, Wah. Now we have completed the two sides of the story. I think it's time that we're gonna ask the people some questions. I think, Kazu, you being our panelist, after you listen to all this, have you got any question to ask our presenters?
Yes, thank you for very nice presentations. So regarding the starting age of bariatric surgery, I would like to ask all of you, including Ken Loy, when did you start your first bariatric surgery? Actually, I started my first bariatric surgery 20 years ago when I was 36. So at that time in Japan, everybody thinks that it was too early to start the first bariatric surgery in Japan. But when I went to other places like Brazil and the United States, the same age surgeon is already an expert of that field. So I'd like to ask all of you, when did you start bariatric surgery at the first time?
Well, Kazu, I'll speak. My camera's not showing yet, but I'll see in a second.
Yep.
I did my first bariatric operation before all of you were born, which was in 1974. We did a jejunal arterial bypass back then, and the earliest bariatric surgeon, Mason and the boys, were doing it in the late 50s, early 60s. But in Australia, we started in 1974 to start doing bariatric surgery. And I won't tell you how old I was in 1974, but I was about the same age as you were after when you started.
Thank you, Harry. So when I started my bariatric surgery, Harry and Pradeep is already a superstar at that time. And I always respect both of you a lot.
Thank you.
How about the young guys here?
Is he referring to Ken?
Ken?
Oh,
Yeah.
well, I'm middle age, so I cannot call myself young now. So I think Jai is
Yeah,
younger.
relatively young.
Yeah, not young anymore.
Yeah, so I mean, in Singapore, Singapore is relatively a young country for bariatric surgery itself. So we did, a small amount of bariatric surgeries in the 90s, and that's where, because the incidence of obesity and metabolic disorders in the 90s was low, and since then it has actually creeped up very steadily, and so bariatric programs and all that started in the early 2000s, and then it actually progressed up, and now it's very full-fledged and established over the last 15 years. It's much more established. So at that time it was still a very niche field that just one or two surgeons were doing, who were trained in the field, and most general surgeons didn't want to venture into that field for lack of awareness, as well as dedication into that field. So it was mainly general surgeons doing it. So personally, I started doing in the early 2000s, but overall at that time it was not, I still remember in Singapore it was just one or two surgeons doing it, and it was a low volume, but then slowly it kind of creeped up. And most of the time initially we were doing gastric banding, and it was probably the single surgery that was being done for all patients with obesity. It's only then in the so-called early 2000 to about 2005, then sleeve gastrectomy started becoming popular. And then when some of us, I would have to say that myself, Asim, and Shankar in Singapore, even though we are younger than you guys, we probably those that started the programs in each of our hospitals to make it more standardized, and doing other surgeries such as gastric bypass and sleeve plus procedures, etc.
Very fair, isn't it? Yeah, I mean, Kazu, I think to answer your question, I don't know, being all of us like now kind of did a fair bit, and we don't call ourselves old, we don't call ourselves young anymore. I think a bariatric is kind of almost becoming what we call the upper GI surgery or advanced laparoscopic surgery, isn't it? Which most of the people have skill nowadays. And I remember doing it first time for the last 15, like I think 15 odd years. Maybe I call myself young as well, but at that time, I think is watching Harry and a couple of the other guys doing it. It's after you do bariatric surgery, a lot of the other surgery become relatively easy. I think it's because you used to handle bigger patients and more complex surgery. So it does upskill yourself, I think. So I think that's one of the advantages. So you're going to carry on with the skill now. The next phase could be robotic, could be other things coming up. So I'm pretty sure we can convince Harry to jump onto the robot, isn't it? Have you tried the robot yet, Harry?
I actually have tried a little bit, but not very. I haven't done any operations with robot. I'm more training on a bit, sort of experimentally. But can I just say that now in Australia, and I'm sure in most countries, there are bariatric training programs as part of the general training to be a surgeon, and that's very important. There are more bariatric operations done in Australia than general surgical. In other words, there's more bariatric operations done than gallbladders and appendices. Now, that obviously didn't happen. It just slowly increased. But now every general surgeon, I think, does some degree of bariatric surgery, or most. And I'm not sure whether it's the same in Singapore or in China or Kazu in Japan. Do you have big, large bariatric training programs within your societies?
Yes, so in Singapore, it has now become official, and usually the upper GI surgeons are the one are basically tasked to do that program in their hospital, and it has become a part of the traineeship, and they have to do this many number of cases, and it's a very structured program. Also in Singapore, if you want to practice bariatric metabolic surgery, you have to take a special insurance. So there is a special insurance category for bariatric and metabolic surgery. So actually, in general surgeons can't do, are not allowed to do unless they are taken that insurance policy. And that insurance policy is 4 times the cost of general surgery insurance. So if you're not doing a dedicated program, you do not want to spend that kind of money for your insurance.
Wow. Maybe I think
we have to take out special insurance as well, or they charge us more if you do bariatric surgery. Kazu,
yes,
in Japan, do you have good training programs?
Actually, in Japan, there is no systematic training program. But to tell the truth, in Japan, only my hospital is a high volume center. So that the young fellows came to my hospital and learn and go out to the university and then start the new program. So that actually there is no systematic training in Japan, just training in my center, or the expert like me go to other hospital and mentoring a few cases, then they started their own bariatric practice.
CC.
Not as good as.
Yeah. CC Wang, in China, is it special places?
Can you hear me? Harry, this topic is very interesting. I want to know how old age is best for bariatric surgeon? Maybe 40, maybe 50?
Yes, well, I think I would have thought that, once you've been trained as and you got your training and you got your postgraduate training, you can certainly start doing bariatric surgery under supervision. There's no doubt about that. But also, there's a big difference between primary bariatric surgery and revisional bariatric surgery. I think most of you agree that revisional bariatric surgery is a lot more difficult and it requires more training than doing primary sleeves or something similar to that. And that's where I think the big difference is. Let me tell you that as you get older, you see changes from bands to bypasses and bands to sleeves and bands to all sorts of things. And soon, most of you, not myself, because I'll be retired by then, you'll see a lot of changes from sleeves to different operations, including SARDI and SIDS and all those operations. So it's revisional bariatric surgery is certainly more difficult, but primary bariatric surgery can occur once you've got your general training.
Thank you, Harry. I think this is the word of wisdom, isn't it? I think the world is like Yang says, a circle. We respect our elder, they teach us things, and we pass on our knowledge to our junior, and they will be, our age soon, and they can circle on that circle of life. And this is not intending to be a debate. In fact, I think it highlights the depth and the experience we have in Asian Pacific. A lot of the country are in different stages of development for the bariatric program. And as a friendly society, we're all friends, we see each other all the time. COVID and all these things dealt us a very bad hand at the moment, but I'm sure when we're coming together, we can celebrate, we can share knowledge. That's what this society is for. And as we say, Ifso is apolitical, we are all friends. Doesn't matter which country we are, and we should support each other in good time and in difficult time. And I think we may move on, but before that, I think hopefully Professor Wang's internet a little bit more stable. Maybe before we move on to our next sessions, we all agree you can work as long as you can, and you start as early as you feel comfortable with, and you get patient. So maybe that's what we agree on, isn't it? Professor Wang, you want to say a few things before we move to our next sessions? Professor Wang, do you want to say little thing before you start the next session? 要讲几句吗？听不见。
Can you hear me?
Yes, 可以。
Very sorry, the internet has some trouble. Thank you, everyone, for wonderful speech and discussion. I think the topic discussed today is very interesting. Thank you all very much for your continued support and participation in Ifso APC activities. Also, we have not seen each other for 2 years due to the pandemic. We still conduct academic exchange through the internet. The 2022 webinar will be held on July 14. Please do more to come and share your idea with us. Hopefully, we hope we can meet at the Ifso 2022 World Congress in Miami this and at Ifso APC 2022 in the Philippines in November. Thank you.
Thank you, Professor Wang. I think we'll carry on to the next sessions, and I'm going to invite another senior surgeon to be our moderator for the next session, Professor Asim Sharpi, and he's also working in Singapore General Hospital, and I think we started off around similar time, and he very quickly become well published, well operated, well integrated with a hospital system that bring up the standard of Singapore bariatric surgeon together with JIDEP and etc. So welcome, Asim. I'll pass the session on to you, and we'll have the next session on for the Ifso APC session now. Thank you.
Good evening, all. Thank you very much. That was a really excellent session. Thank you very much for all the Ifso APC colleagues for the honor to host this session today. Thank you, Professor C.C. Wang, our current president. I would like to take this opportunity to introduce the topic first. Our topic for debate today is chocolate versus smoking. What is worse for bariatric patients? Today, joining me in helping with the session, I have two panelists, Dr. Tam Kongwei and Dr. Simon Wang. Can I have Dr. Huangwei and Dr. Simon up here? Are they on the? There we go. Thank you very much, Huangwei. And right, Kongwei is basically currently the president, our endocrinologist among all the surgeons. Great to have you. Thank you, Kongwei. Kongwei is the president of the Singapore Association of the Study of Obesity. She is for the Ifso Apc, the vice chair of Integrated Health Committee. She will be one of our panelists. Our second panelist, I will introduce him and join in a bit, is Clinical Associate Professor Simon Wang. Simon basically hails from the Chinese University of Hong Kong and is working at the Prince of Wales Hospital in Hong Kong as well. Very well published with 161 publications to his name, and he is the immediate past president of APMBSS. Before we go to the talks and I get introduction of the speakers, I think we have a poll for you. May I call upon Manuela? All the audience can poll. You can poll now. So let's see, at the end of the talk, can we have to see whether we can swing the things around. Chocolate versus smoking, what is worse for patients who've had bariatric surgery? So remember, these are patients who've already gone through bariatric surgery. Should they smoke or should they have chocolates? I know all of us would say neither, but let's try and see which is worse for them. Oh, wow. All right, everybody. Wow, I love that. That's great. Let's see whether we can get some people go over to the other side. Thanks, Manuela. So 100% go for with smoking. All right, lovely. Nice to see that. So our first speaker, who's going to speak on smoking is none other than our well-known president to be in future, the incoming president of Ifso Apc, Dr. Ken Loy. Dr. Ken Loy from the St. George Obesity Surgery in Australia. The current president-elect for Ifso Apc will be speaking on smoking. So Ken, over to you.
Welcome to the debate about smoking in bariatric surgery versus chocolate in our Ifso Apc sessions. Apologize cannot attend in person, but hopefully we can have some discussions regarding of the following sessions, whether smoking or chocolate eating is worse in our bariatric patients. I suspect that we have to frame the question first. The main thing we're going to discuss about is cigarette smoking, possibly vaping, the effect on our patients, and also potentially for our Middle East colleagues on Habib and also the shisha. We're not going to discuss about substance using such as marijuana. I think it's been well documented that smoking associated with quite a lot of surgical complications, not only just in bariatric disease, but cardiac issues and hernia problem. And it's concerning enough that when we're doing our systematic review by the Canada group last year in SAGES, they found quite a fair amount of study that satisfy the criteria to look at, especially longitudinal study on follow-up to demonstrate the problems associated with smoking. And this is in terms of mortality and complications, particularly wound problems and pulmonary complications. and all those reports demonstrated that there is a vast association between smoking and worse outcome. From surgeons' point of view, we're of course concerned about surgical complications. We always try to ask our patient to stop smoking before any form of surgery if possible. This is part of public health that we've been doing that for a long time, and we've been doing that successfully and leading towards not the demise, but at least the awareness of smoking associated with health problems in lung cancer, etc. But there's a strong association between smoking with patients with death, because we're dealing with particularly our bariatric patients who already had quite a high degree of metabolic problems and potentially complication associated with stroke, myocardial infarctions, DVT, PE, wound infection, and pneumonia. All these can affect directly the outcome and also the mortality of the patient as well. And in 2021, lately, we also showed that they staying longer in hospitals and have higher chances of readmission rate. And I guess also not only affecting long-term wise about surgical complications such as marginal ulcers in bypass surgery, it affects metabolic absorptions of calcium and vitamin leading to bone fracture, which I'm sure Stephanie will cover. And when they use large population study to look at the NESQIP data on 13,000 patients undergoing bariatric surgery, they identified 10% of them were smokers. And when they follow up their outcome, they found statistically substantial difference in terms of death, wound problems, and respiratory issue. All these are associated with longer length of stay and potentially can negate the effect that the patient will benefit from in terms of weight loss and resolution of comorbidity. This is particularly associated with gastric bypass operation, which for American has been doing that for a long time. And when they try to apply to look at sleeve gastrectomy, as we know, sleeve gastrectomy now is probably the world's still the most common operation now in all the different continents. Cleveland Clinic tried to see if patients who smoke, is there any contraindication for them to have sleeve gastrectomy? Because on one hand, sleeve gastrectomy is relatively simple and easy to perform. But if patient who smoke leading towards more adverse event, then patient need to be discussed with. And sure enough, they do find that, again, the morbidity events and mortality are slightly higher, and it's actually statistically significant. But not to the state that they would counsel or not offer the patient who smoke to have sleeve gastrectomy, but they should, at least for the sake of reducing perioperative complication, to stop smoking before surgery and potentially afterwards to ensure that healing takes place. Because as we are aware that healing not only require food, nutrition, and good surgical skill, but also oxygen, which smoking has been in smokers has been reduced. And particularly my anesthetist told me that in terms of anesthetic issues like reintubation, laryngeal spasm, and pulmonary edema even are higher in smoker. And also because of a lot of the chemicals that is in cigarette, the cytochrome P450 are particularly affected, which alter pharmacokinetic of potential drugs, painkillers, anesthetic medications administration, and also raise carboxyhemoglobin, again affecting oxygen's permeation to tissues to enhance healing. And some patients say that, or they remember that when they smoke, they always lose weight. And when they actually don't smoke, they put on weight. So a lot of them do went back to smoking despite the fact that they stopped for a little while because they trying to lead a healthier lifestyle and hence they want to have bariatric surgery. But I think unfortunately for those who utilizing the theories, sadly speaking, there may be only 3% of excess weight difference in long-term follow-up, which probably not worth the detrimental health effect that smokers will suffer from. So I look forward to listen to my other speakers and have a bit of look into in terms of dietetic review as well on rate that smoker affecting
in our bariatric populations, and we have a discussion afterwards. Thank you very much.
Seem you muted.
Sorry. Hey, thanks, Ken. That was a lovely talk, and look forward to the discussion. Let's welcome Simon. Simon, we see you, but you seem to be in a little bit of a grayish background. The image isn't clear. Maybe the camera can go a little focused.
I think my computer camera is broken, so it can't focus. Sorry, you have to bear with my beautiful face now.
No, we've
Your
got
voice.
an excellent voice on the background, so we're very happy with that. Thank you very much. Thanks, Ken. Next up, we have Stephanie Gilroy. Stephanie Gilroy works with, I think, Ken. She's a consultant dietitian and an owner and director of the nutritional consultancy business Nurture, Nourish, and Thrive. She's also going to speak on smoking. Can we have Stephanie Gilroy video played for us, please? Hi, Steph.
Dietitian at St George Private Hospital, working with Dr. Ken Loy. I'm also a clinical lecturer at Macquarie University, Sydney, Australia. Thank you to the organisers for inviting me to debate today on the topic of smoking versus chocolate, what's worse for bariatric patients. So I'm here to argue that smoking is worse than chocolate from a nutritional point of view. So smoking allows a toxic blend of poisons and cancer-causing chemicals to enter the body and put our internal organs at risk. Smoking creates an abundance of free radicals, causing oxidative stress that can cause cellular damage and deplete essential vitamins and minerals in our bodies. Smoking also increases the risk of gum disease, tooth loss, and also tooth sensitivity. And once a person has gum damage, smoking can make it harder for their gums to heal. Smoking supplies the brain with nicotine, altering and suppressing a smoker's ability to taste flavours. The reduced oxygen supply from inhaling tobacco smoke contributes to the dulling flavor recognition in the mouth. Smoking irritates the nasal passages, which can cause inflammation and impair the sense of smell, and this can influence the pleasure of eating. Nicotine suppresses appetite because of its effect on the brain and the central nervous system. Vitamin K helps to make various proteins that are needed for blood clotting and the building of bones. McEwen and colleagues noted that male smokers had lower plasma vitamin K levels than non-smokers. There's a negative association that was found between smoking and proteins induced by vitamin K absence factor 2 by Wang and colleagues in 2015. Vitamin C is a water-soluble vitamin, and so it's unable to be stored in the body, unlike vitamins A, D, E, and K. So we must get vitamin C from the foods that we eat each day. Vitamin C is needed to make collagen, a protein which is responsible for growing and repairing cells in our bodies that produce skin, muscle, ligaments, and blood vessels. It helps to keep our immune system strong and reduces blood sugar levels. And it also has the unique quality of being able to help with the regeneration of other antioxidants such as vitamin E. Studies have found that people who smoke and those who are also exposed to secondhand smoke have reduced amounts of vitamin C in their bodies. Smokers require more vitamin C per day than non-smokers. Lickers and colleagues demonstrated plasma vitamin C concentrations are reduced by up to 40% in male smokers. They then corrected for intake of fruits and vegetables, finding smokers still had lower plasma ascorbate than their non-smoking counterparts. Kalner and colleagues also noted that the metabolic turnover of ascorbate is markedly accelerated in smokers. As smoking is a known factor for contributing to bone loss, smoking may interact with 25-hydroxylase in the liver, leading to reduced levels of 25-hydroxyvitamin D. Less vitamin D absorption leads to less calcium available to strengthen bones. In our sleeve cohort at St George Private Hospital, we found that almost half of our patient group had pre-existing vitamin D deficiency. We didn't at the time look at how many of those were smokers, unfortunately. Smoking is a risk factor for osteoporosis and in women may result in early menopause compared to a non-smoker. Vitamin E is an important nutrient that helps us to build red blood cells and bolsters the immune system to fight off viruses and bacteria. Like vitamin C, smoking appears to increase vitamin E requirements. Vitamin E is one of the first lines of defense against the free radical damage to the lungs when we breathe in air pollution and cigarette smoke. So to conclude, at present, there's limited literature examining the association between nutritional deficiencies and smoking following bariatric surgery, so further work is needed in this area. However, the nutritional status in smokers may be further compromised by an inadequate diet, and studies show that smokers are less likely to consume fruits and vegetables. Smoking a pack of cigarettes a day costs about 100 Australian dollars a week, and spending on cigarettes may mean less money for essentials like good quality food. Based on the current information, it's too early to state that the antioxidant vitamin supplements are certain to prevent or ameliorate the overall tissue damage caused by cigarette smoke. Thank you.
Well, thank you very much, Stephanie. That was a great talk, and we'll reassemble at the end of the session for question and answers and discussion. Our next speaker for the day, it's going to be, let's see, who shall we choose? Professor Weijie Li. Professor Weijie Li is well known in the field of bariatric metabolic surgery in Asia, one of the fathers and the leading experts in the field of bariatric and metabolic surgery in Asia, has been instrumental in training, has been inspiring in research extensively and very well published across the globe, and still has a very active presence in the field and operates extensively. We would like to welcome Professor Weijie Li. Professor Weijie Li's presentation is going to be on chocolate. So it's the chocolate era. Let's go to the chocolates now.
Hello, everyone. I'm Weijie Li from Taiwan. I'm very happy to join this interesting debate. My job is to debate which one is worse, chocolate or smoking. And I'm speaking about chocolate is worse. Of course, chocolate is worse because chocolate may ruin your surgery, which you should take the responsibility. And smoking may jeopardize the patient's life, but that is his or her choice. So we already have the answer, right? So now I'm trying to explain more detail. So I will look at the background and primary goal and the treatment. So the background is why it is bad, chocolate and smoking. Because I think chocolate may decrease weight loss because the patient loses of the control of his or her eating. And that is not a good sign of bariatric surgery. And the sweet may cause dumping syndrome and decrease the diabetes remission. And that is why it is bad for bariatric metabolic surgery. And for smoking, I think the most important risk is marginal ulcer after gastric bypass. It's about 10 times risk compared to non-smoker, and may also increase some GERD symptom. And of course, smoking is many cancer risk factor for many cancers, so it is bad for the patient. And we need to look at what is the primary goal of bariatric metabolic surgery. If we look at so many clinical trials, I think the most important outcome for any bariatric metabolic surgery is weight control. Then some study may look at the diabetes remission. As far as I know, there's several studies look at hypertension and sleep apnea, and may have some other comorbidity. This is a primary goal, so we should look first upon this. And the secondary goal usually is the surgical risk, long-term complication or quality of life, and this may relate to smoking. And primary goal is always related to chocolate. So which one is important? I think the answer is clear. And the last is about the treatment. Once you have a complication after chocolate or smoking, how do we treat? For weight regain, I think there are several options from lifestyle modification, medication, and endoscopic procedure, but I don't think it is a good effect. And about surgery, it's also very difficult, and the result is usually not so satisfactory. So it's difficult to treat. And for marginal ulcer, I think we have a good medication like PPU. It's quite effective to control the symptom. And for intractable marginal ulcer, we can do revision surgery plus the truncovagotomy. In my personal experience, it's quite effective. So which one is easier to treatment? I think the complication after smoking is easier than the chocolate to be treated. So my conclusion is quite simple. Of course, chocolate is worse because chocolate may ruin your surgery, which you should take the responsibility, and it is difficult to treat. And for smoking, of course, it may jeopardize the patient's life, but that is his or her choice, and the treatment is easier than weight regain. So in a surgeon's perspective, I think chocolate is worse than smoking for bariatric metabolic surgery. So thank you very much. That is my debate. Hope to see you soon.
Well, thank you very much. Thank you very much indeed, Professor Weijie Li. Can I get Dr. Simon and Wang Wei up? So great. We've got some questions in the chat board that have come in, Simon and Wang Wei. Dr. Wang Wei, there she comes. Lovely. you guys have any questions first, you get the first bite. To the speakers, what do you think about it? What are your personal views? Can I have them? Kongwei, sorry, can't hear you up. Right. While Kongwei,
speaker for, yeah, one more speaker for the chocolate. I think it's Miriam's.
Yes. So
chocolate,
you also chocolate. And Simon?
Oh, this is very interesting debate on these two topics. One is life, one is habit. So, but before that, I think we have one more video, is it?
Yeah.
Yes, we do have, but I want your choice and see whether Mariam can change both your votes.
I would choose smoking is more dangerous.
Lovely. Thank you very much, Simon. And hang on there. We've got one more speaker, Mariam Lakhtawala from India, who's a dietitian, and she is going to go with chocolate. So because dietitians would have the last bite in the chocolate, so let's see whether we can swing around votes. Mariam, over to you. Let's play Mariam's videos. Thank you.
Hello everyone, my name is Mariam Lakrawala. I am a registered dietitian and a bariatric nutritionist from India. So today I'm going to be talking about how chocolate can be worst for patients, for bariatric patients. And though I'm not going to be telling that it's going to be worse than smoking, because like smoking, chocolate consumption can actually choke. So chocolate, when we think about chocolate, it is actually known to be an indulgent. You generally would consume chocolate to feel better, to become little happier if you're sad. So chocolate is actually considered to be a very rich food that elevates mood. So before we talk about what could be the harmful effects, I would like to highlight what exactly chocolate consists of. So it basically consists of the cocoa solids and the cocoa butter. And the cocoa solids is the one which is the healthy part, which contains all the vitamins, minerals, fibers, and polyphenols. And these cocoa solids are present in more quantities within dark chocolate, that is more than 35%, compared to the milk chocolates, which are commonly consumed by almost half of the population, which prefers milk chocolate. The content is only 10 to 12%. Now, as I said, that the cocoa content is mainly responsible for various health benefits that we think when we think of chocolates. That is, it helps in the cardiovascular health, brain health, immune function, skin, cognition, etc. However, during the process of making chocolates, the processing itself makes most of the cocoa not very available. Also, generally, these chocolates have a very high content of sugar, which sort of neutralizes the benefits. It's a very energy dense food. Mostly the calorie content is more than 500, mainly because of the high fat content. And these factors actually make chocolate a potential threat to health, especially in the population that suffers from obesity. So what are some of the harmful effects of chocolate that we see in the post-bariatric patients? So chocolate has shown to increase acid reflux, mainly because the cocoa in chocolate causes the esophageal sphincter to relax because of the serotonin release, which could cause the gastric contents to come up. The caffeine and theobromine in chocolates could also trigger the acid reflux. Because chocolates are high in sugar and fat, it can lead to dumping syndrome, wherein the food gets dumped and then the patient experiences various symptoms, early and late dumping symptoms, including nausea, vomiting, drop in the sugars. And definitely hypoglycemia also is commonly seen. And this is mainly due to the sugar and fat content of the chocolate. And as I said earlier, the energy density, which over a period of time can definitely lead to weight gain. One more thing that is commonly seen is addiction transfer. So there is a lot of stress that the patient undergoes even after surgery, because there's a lot of adjustment issues with the body, with the food, eating behaviors, the stress of losing weight, which is very constantly playing on their head. There could be also history of mental trauma or issues, inadequate support from the family, loneliness. All these things constantly puts them under pressure and stress, and there is a tendency to replace one compulsive behavior with another. So many a times they know that things like smoking could lead to ulcer formation and could be very hazardous to health, so they think of maybe relying on foods because they feel that would be a safer bet. And definitely more the consumption of chocolate, more will be an increase in the cravings, and it could also become habit forming, which gradually leads to weight regain. Also, it is seen that people suffering from obesity have a faulty neuroendocrine mechanism. They have shown to have an overactive response to one of the stress mechanisms of the limbic hypothalamus pituitary adrenal axis, and this overactivity lowers the serotonin level and causes a change in the brain chemistry. Now, this change in the brain chemistry increases the cravings for carbohydrates, fats, increases appetite, decreases satiety, and sugar and fat coupled with taste and smell stimulates the dopaminergic activities or the reward system in the brain, producing feelings of happiness and joy, which sort of is produced similarly with substances like nicotine, cocaine, or alcohol. So now, over a period of time, the low levels of serotonin and the enhanced LHPA activities, what it is down-regulates or blunts the dopaminergic response to the stimuli, and this further in turn causes increased dependence on food, and there is further increased cravings and increased consumption, and this all has an adverse long-term effect eventually. So yes, since weight regain is something that is perceived as the biggest health concern post bariatric surgery by patients undergoing bariatric surgery, because that is what they've been suffering with all their life. So when they start seeing weight regain, the fear of weight regain is very, very big, and thus definitely frequent consumption and too much consumption of chocolate can lead to worst weight loss outcomes post bariatric surgery. So I would say that the plan of action for every bariatric surgery team should be to identify whether pre-operatively the patient is having any food or substance addiction, to then identify the cause if there is, with the help of a psychologist, to also help them with coping strategies, because this kind of approach will thus favor the best outcome post bariatric surgery. So like I said in the beginning, um, chocolate exactly would, it would choke you like a smoke. So definitely chocolate is a worst thing post bariatric surgery. Thank you.
Thank you, Mariam. Thanks, Mariam. That was a great talk. Can I get all the panelists and all the speakers, please, to on their cameras? There we go. Steph is there. There is Mariam. Is Prof Vijay around? Yeah.
Yes,
Okay.
I'm here.
Oh, lovely. Okay. Okay, there. Then now we're able to see you finally. That's good. All looking great. Thank you very much. We've got a couple of questions in the chat box, but before we go to the chat box, my panelists, how would you view? Do you want to take this on from here? Simon Kongwei.
Yeah, I'd first like to congratulate all our speakers. Very good effort on the presentation. Thank you so much. I think it's a tough topic. I think at the end of the day, for me as an endocrinologist, I need to look at the outcomes. I mean, smoking not only just affects the person, it also affects the people around them, secondhand smoking and other effects. And I think chocolate, it depends. If we talk about chocolate with weight gain and all that, it's also no good. And in fact, there was an interesting study just recently published looking at the timing of when we eat chocolate also has benefits. When you just eat chocolate in the morning and at night, it actually does suppress appetite. And so it depends on the type of chocolate. So at the end of the day, in the big scheme of things, if you ask me to choose, I think smoking would be more hazardous for the person. And actually smoking, to answer some of the questions that were posted online, whatever form you whatever form you consume nicotine through a patch, inhaling, e-vape, it's nicotine. So nicotine is the one that has a lot of hazardous effect of cancers and all that. Vaping also has vitamin E and all the THCs and a lot of garbage actually that harms the lungs as well. So I think it's just cigarettes and smoking. With chocolate, if you will have me to manage, you know, I can manage the sugars, or I can ask them to compensate with exercise, ask them to choose more dark chocolates, which actually have flavonoids, are more beneficial for health. And then my last sentence as a medical person would be, I think we need to treat this whole thing as a form of addiction in a sense. I think it's obesity is a disease, it's a lot of energy deficiency, but also other things that affect them. So we don't address all these. Chocolate is just eating a lot of chocolate is a manifestation of, you know, I'm having cravings, right? Same with the cigarettes. And we need to engage patients not just before surgery, because 6 weeks off cigarettes is easy thing to do. Get on VLCD, easy thing to do. We need to keep engaging them, I guess, throughout the rest of their lives, you know, to stay off whatever it is, whether it's their favorite foods that cause weight gain or cigarettes. Yeah. So, but at the end of the day, I would choose cigarettes to be more hazardous. Thank you. Over to you, Simon. Before.
Yeah, I definitely agree with you. But my point is, have you ever commonly see smoker? Yes, I think all of us easily get one or two in your clinic. But have you ever that commonly see a chocoholic with craving every day for chocolate in your clinic? I don't think so. This is not that common behavior. And also for chocolate, I don't think the people or someone will have a great amount of chocolate calorie in the volume that gives you a very big weight change. And also surgery itself actually can change our satiety and also tasting. And some of our patients after surgery, they do nice sweets afterwards. So this chocolate problem, I think, is still correctable. You can have a very less milky and less sweet chocolate to compensate your chocoholic behavior and so on. So, but smoker, I have hardly see someone really quit smoking that easily before or after surgery. So I think smoking is a very big devil as parallel as obesity itself. That's my opinion.
Thank you very much, Simon. Ken, I have a question from the audience for you. Is there any difference in risk between cigarette smoking versus shisha? Shisha is the Arabian form of smoking that bubbles down the wood. Smoking cigarette versus shisha versus vaping. Wow, that comes in nicotine. Is the risk to lungs or anastomotic ulcer primarily from the nicotine or any other form or certain form of smoking nicotine? And the question is from Selena Ward. What are your takes on that?
I know Selena quite well from Melbourne. So say hi to her. Thanks for logging in as well. I think when I was looking at the literatures, the interesting thing that come out is, as I say, smoking. Actually, the nicotine itself, everyone is hammering on. It's just the addictive component. There's about 6,000 toxic chemicals. Some of them I can't even names on the package that you can see. So those are the things that actually causing your other problems relating to metabolisms. And I think they interfere with increased acid secretions and reduce mucosal defense. I think you all know about why smokers and other people taking non-steroidal get ulcers, and that was a long time ago before the PPI, etc. And I think if you look at the registry, you actually get some fair idea. The country that who smoke, especially the Middle East itself, maybe depending on the surgery they do, they're probably doing more bypass, etc. I think the complication rates and marginal ulcer rate sometimes can be quite high. And often people, you know, the only thing I can say is I agree with Professor Lee is that I think smoking everyone know is bad, but chocolate is kind of like a stealthy assassin. So, you know, it's not as commonly labeled as very bad. So it can creep back into you. Whereas if someone, you know, all the family members, everyone will say smoking is bad and counsel people against it. Yes, and then people now the cigarette company giving a lot of credit to them. They try to make vaping sexy. They try to encourage people. Shisha is a social thing. It tastes sweet. It doesn't taste smoky at all. So all these are there to enhance your habit. So they've done really well on there. But to any of our patients, I think if you add the psychology opinion on it, any addictive behavior, if you tell them to quit completely, is doomed for failure. So you always probably can try to tell them to reduce it and control it if you can, but completely cut it out sometimes is really hard. The relapse rate is very high. Maybe I didn't answer properly, but I certainly think that the marginal ulcer, especially the small bowel mucosa, are the one that usually have issues associated with smoking that you will see in your practice, Alina.
Thank you. So, Stephanie, thank you very much. You know, people like to cheat in all ways. I don't smoke, but I can chew gums. I have a question from Dr. Tae Convoy from Singapore. Thank you for the question. Any experience with patients who are on nicotine replacement therapy, whether those are gums and patches, and plan for surgery? Do you have any concerns letting these patients of yours go through surgery?
That's a question for me.
Yes, Steph.
Yep. Okay. So thank you for the question. I guess you know, patients are always trying to do their best and prepare as well possible from a surgical point of view. So I think if they are, you know, trying to move away from, you know, the addiction and trying to get some support from a smoking cessation point of view, I think that's another step on the path to the road to improving their health and overall well-being. So I'd be congratulating the patient on doing that. In terms of whether or not it's any more sort of negative, I guess it's going back to Quang Wei's comment about how it's still obviously a source of nicotine and something that we should be encouraging our patients to sort of slowly try and move away from.
Perhaps seem a bit unfair to ask Stephanie the question. I'll answer for Stephanie. I have used nicotine patches and things, and the reason why I use it is not to replace the cigarette. It's to take away the addictive component. As you hear, the 6,000 chemical that you inhale is the one that actually damages your lung. Your anesthetists hate it. They wake up coughing. They increase abdominal strain. They rip your staple line. They burst your vessels in terms of where you seal. You get more complication associated with that. So my anesthetist told me that if you can stop smoking for 3 weeks, your PO2, which oxygen, which is your lung level, the oxygen level afterwards, will increase dramatically. And as you know, oxygen is actually a things to heal, not just food. My dietitian tell me that you need protein, you need this and that. Oxygen is very important in acute phase of healing for surgery as well. So that's exactly what I aim to do. I'm saying that once you heal, it's your choice to smoke. If you get perforation ulcer, I'll fix you up, but that's your choice. And usually with bypass, I put them on 6 months worth of PPI, by the way, just a protection anyway for that. So that is the rationale of using replacement patches, is not to completely replace that, but to at least get them a brief period of time to not to smoke, to increase the oxygen level in the lung.
Thank you. Professor Wijali, I have a question for you, which comes from Professor Janrive, and is surgical revision of marginal ulcer an option in patients that do not stop smoking? So if a patient does not stop smoking, would you do a revision of that person?
Of course. The real world smoking, like the habit, is not easy to quit, but you still need to treat the patient. And I think in my experience, truncal is quite effective. So usually in this kind of patient, I will recommend to do a truncal. And sometimes if ulcer is really big, I will try to resect the ulcer and the re-anastomosis. And in my experience, the result is quite good. Yes.
Thank you. Mariam.
I think, can I also add in as well? I think when you revise it, you also excise the more stomach. So it's probably proportional to the amount of parietal cell you have in the stomach that secrete the exit that will cause the, besides the truncal vacotomy as well. So that's probably help both together, isn't it, Professor Lee?
Thanks. Mariam, 60% coca, 70% coca, 80% coca, 90% coca, or chocolate with milk? Where do we go? Where do we draw the line?
So like I mentioned, more the amount of cocoa content in the chocolate, the healthier it is, because it's actually the cocoa content that matters. And definitely milk chocolates will be unhealthy option because they will also be accompanied with a lot of sugar. So definitely higher the cocoa content, better is the chocolate.
Okay, so you would still let people have some cocoa, right? Because the smoking guys are saying no smoking, right? But the chocolate guys are saying it's okay to be sinful, but sinful in a decent way. Am I right to say that? You can have your indulgence with cocoa with 90%.
Yes, definitely. We can definitely help the patient. I think that is what we dietitians are for, to make the patient more comfortable and also to adjust to the changes and help in the dietary way. And definitely here, if we have to compare, it's more of the addiction that we are worried about and not the, I mean, you know, less frequent consumption of chocolate. I don't think that's a concern.
Thank you. Kwong Wei, there's a question out there, and I think surgeons may not be the best people to answer that. Vaping versus smoking. I have no clue. What are your thoughts? Do you have any thoughts?
I think, okay, vaping firstly, I think has been sexified, especially for the young people, because, you know, of the kind of negative connotations with smoking. But actually, there are reports actually of harm. So it does cause cancer because it has nicotine, and as mentioned, it also has a lot of chemicals, things like actually quite high in vitamin E and actually some kind of cannabinoids. So these and other chemicals, like Ken has mentioned, actually has many other chemicals which can then cause cancer, heart disease, actually even cerebral vascular disease. And actually the long-term studies are not, because it's not been long enough. But if you go to the CDC websites and all that, there are these warnings out there. In fact, things like Juul, you know, I mean, there've been reports of people going in with acute pulmonary problems and having young people having difficulty, you know, recovering and all that, lung damage, common lung damage. So I think it's also addictive as well. So I would say that again, it all boils down again to this whole habit. So I think kids who then pick up vaping do tend to go on to cigarette smoking as well. It's been reported. Yeah. So actually, pertaining to bariatric surgery, apparently there was a recent systematic review of smoking or e-vapes and what have you, and they couldn't find any studies with electronic cigarettes or you know other forms of actually smoking, basically. Okay. In terms of bariatric surgery outcomes, but so I think we do have patients who do that. I think we need to look into that, even a nicotine replacement. Yeah. So that's a long and short about vaping. I mean, I could have missed some things.
Thank you, Kwong Wei. Kwong Wei and Simon, do you have any questions for our speakers here?
Actually, I have one question for the surgeons in general. So I think, do we know exactly what causes the ulcerations then? Is it the actual, or it's just an association? Sorry.
I mean, you got to go back to all the history on stomach ulcer, isn't it? I mean, you know, age, male patients, you know, family history, H. pylori, you know, all sorts of different things, and you got to throw it all together. So you individually assess. I mean, the telltale sign you have is they get pain when they eat. So it's actually a vicious cycle. So when they get pain when they eat, they take painkillers, and most of the over-the-counter painkillers are anti-inflammatory. That's make the ulcer worse, and they get more pain, and they get more painkiller until they landed in emergency with perforation or some sort of irreversible thing. So I'm sure every one of our surgeons here probably get a few handful of people with marginal ulcers. And in fact, I think their weight loss is actually quite better compared to a lot of patients because they're actually too scared to eat. It gives them pain. And sometimes the only thing they can eat is actually chocolate. So then you get both together. That's actually even worse. You got double dose. So, you know, not necessarily if they're smoking and they don't declare to you, that's the problem. And if they don't, patient don't tell you, you can't help them. That's again, the issue that we've been drilling on is an addictive behavior, both of them. And if they're honest about it, you can help them or whatever way you can. But if it's not honest, it's not about just physiology, mechanical, or whatever way it is. You know, it's just difficult. We are dealing with a difficult group of patients. So you know, stop debating everything. Everything is bad. Just make them lose weight, as Professor Lee said. I think he's working hard at the moment.
Thank you very much. Manuela, can we run the poll again one more time? Let's see whether we have some guys joining the other cohort. We were just unilaterally swayed to one side, 100%. Can the participants please poll again? There was a request to add chocolate and smoking together. Since we had polled before, we just wanted to carry on with that poll. So let's poll now. Okay, shall we? Oh, wow. Well done, guys. The chocolate have done some fine work here with the chocolate. They have managed to get about 8% of patients on their side, or rather, shall I say, the smoking group has done better. They have 92 and they have, I think it's worse. So there's some shift in polls. Thank you. Let's come back to what do you think about those polls, Simon? Simon, sorry, we can't hear you, Simon.
I think it is a really great job for our dietitian and Dr. Wei to convince this 8% people to vote. But as a matter of fact, this is not a very fair competition with these two categories. So, but I think it's interesting and everyone do a great job.
Thank you very much. Panelists, do you have any? Well, let's put it this way. Prof Lee and Mariam, do you have any questions for the smoking group?
And I can understand smoking is really not a good thing, yes, but unfortunately my job is a positive side, so I think every bariatric surgeon and colleague is very clear about the side effect. I agree, especially now we have a medication improve our weight treatment. So if you eat chocolate, we will give you semaglutide, so to kill the problem.
Great. Well, I think we are near to the end of time as well. I would like to thank my panelists, Dr. Simon and Dr. Wang Wei. I would like to thank the speakers, Ken Loy, Stephanie, Prof. Lee, and Mariam for this excellent session. I would like to hand the session to the main speaker, back to our president, if we can get Dr. C.C. Wang over. Thank you very much to the participants for joining us for this session as well. Thank you all. Thank you very much. I appreciate you. Good night.